So if you think of just our discussion, I thought that visceral patients needed to get chemotherapy, and I think Latitude proves me wrong, because if you look at the patient makeup for Latitude, roughly 14 and 17 against charted high volume disease by virtue of visceral disease. So do you really think that visceral disease is what most people are saying right now that should be utilized to define chemotherapy?
Yeah, I mean, I think that's a great question, and that's what Alicia was talking about earlier. And I think this is where this whole shared decision making comes in. I do think, to Neil's point, if they're younger, I do think they tolerate it well. And I think for me, I think, okay, if it's me, I'm a younger guy, if this is my level of disease, I'm gonna probably do that, so I'm gonna recommend that. But I do think if they sort themselves out for various reasons, they can't tolerate it, it's financially, unacceptable because they have to take time off from work, then I think I would move them towards AR therapy. But for the most part, I agree. I think if they're younger, they can tolerate it. I would move to 6 cycles of docetaxel first.
So it's interesting.
Even though, like you said, the data is a little bit.
I don't think we're going to be able to compare across trials, clearly,
right.
And what is intriguing is that, I was part of the ECOG data, and as of June 2017, I moved completely away from chemotherapy to oral therapy. And which brings to a point as to, are there any absolute contraindication, medical ones, that you should say, maybe I'll do chemo instead of an AR inhibitor or a bioinhibitor?
So I was going to ask you, so what if you're concerned that the patient has a poorly differentiated neuroendocrine tumor, has visceral metastases, low PSA, lytic bone lesions? Are you going with an AR, or are you going to go with taxane, possibly carboplatin combination?
I would actually, you raise a great point. So if I know that the patient has significant neuroendocrine differentiation of a small cell component, my approach is not an oral agent, my approach is chemotherapy. And when I'm selecting cytotoxic-based chemotherapy, I would probably just talk about a carbo-based approach or a platinum-based approach. And the bigger question right now for us would be, do you do carboetoposide, typically small cell phenotype, or do you do a carbotaxane? We finally have the publication from Anna Aparicio and Paul Korn of what we define as the MD Anderson regimen of doing carbocabazine for those patients with AR null disease. I oftentimes don't do carbocabazine at front. I probably would use carbodosi, so I can reserve cabazitaxel for later. But yes, I have to know that they have a true neuroendocrine phenotype before I do that. Alicia, would you?
I agree with you completely, and I think it's always important to talk with the pathologist if that's what you think that you're seeing, because synaptophysin can be expressed in adenocarcinomas, and sometimes it gets tricky because they'll report, oh, it's staining for synaptophysin, but they're not actually saying this is neuroendocrine differentiation, and so those conversations become really important. But just to get back to your other question, is there something about a patient that would completely be a contraindication that's medical and not financial toxicity, which I end up seeing actually relatively commonly, a malabsorption disorder. If they can't take a pill and have it actually be absorbed, perhaps, but other than that, it's hard to say if they have, or maybe a seizure disorder, and we can talk about that in the data again if you want, or maybe severe liver toxicity, though of course they're not going to be able to take docetaxel then either, and maybe that's an ADT alone patient. But I'd throw that back at you. Are there commonly seen medical issues? Because none of these are common.
So you're right. I don't think there is an absolute contraindication from any of the oral agents, in my personal opinion. I think my concern is, for instance, if we have an obese male, a cardiopath with CHF, CAD, significant issues with hypertension, I think those patients may do better if they go quickly through docetaxel, right? Because of the chronicity of an AR inhibitor, right? It's a greater risk, in my opinion, for cardiovascular morbidity and toxicities. So that, for me, and I have done it lately, but they're not that common, in my opinion, right? I don't know if you feel the same way, guys.
No, I completely agree with you. Right, if you have somebody who's got fluid retention issues, heart failure issues, AbbVie, and even at 5 milligram, let alone 5 milligram BID, the chronicity of that could be a real issue. But it's interesting you brought up earlier about this whole notion about the concomitant that we saw about 40-45% in the Enzamet. But yet in ARCHES, we saw that about for the 11 or maybe it was 18% in both arms had docetaxel beforehand. If you look at the forest plots, they actually did better, regardless of high volume, low volume, in terms of the RPFS primary endpoint. So, and we published that. So what's interesting to me is, Enza is a CYP4AE inducer, which can have, and DOSI is also metabolized through CYP4AE. And so you were saying earlier, when we were talking about that earlier case, the whole notion of drug-drug interaction. And I think other AR inhibitors, and this is where we need to start to think about, whether it's apalutamide or darolutamide, how that could have an effect on the metabolism of docetaxel. I don't know. And that may actually, that gives me some, still some, optimism for the ARASENS trial.
I agree, and I think it's important, or at least in my practice, I'm not using triple therapy at this point. I think the Enzamet data suggested, which we have to remember, it was concomitant use of docetaxel and enzalutamide, and perhaps because of this issue of the metabolism being through that same CYP enzyme, there was actually a higher rate of toxicity in the triple therapy arm, and it was interestingly the docetaxel toxicities that we saw kind of amplified in that trial. So I'm definitely not using them concomitantly. I've tried to not do sequential until we get to MCRPC, just because I don't know the answer yet. And I am definitely looking forward to ARASENS. I think piece 3, it's piece 1 actually, will help us understand this too, which is also looking at some of these combinations to help sort things out.